Next speaker is Dr. Leslie Hutchings. And Dr. Leslie Hutchings is a family physician who has an interest in teaching, in mental health, and lymphedema prevention. And prior to graduating from McMaster Medical School and establishing her practice in Stayner, Ontario, Leslie spent 4 years as a public health nurse. So I want to welcome you to the stage.
Thank you. I'm happy to be here. I have a co-speaker today, Jan McFarland. Jan is a physiotherapist who specializes in lymphedema care. She runs the Barrie Lympho Centre and also has a clinic in Toronto. Jan's been doing this work for 20 plus years. So we work together. We have a model that is working in our community, seeing clients in educating them regarding lymphedema. Sorry, can you hear me?
That when I get this one.
Oh, okay, fair enough. So we have a model that's working in our community where we see clients, we provide consults, educate them, and move them through this journey so that they can be aware of this possible complication that might arise in their life. So let's start. Sorry, I just need to figure out how to do this. We're going to just start by looking at the lymph vessel system 101. So I don't know if you're familiar with this, but this is what the lymphatic system looks like in our body. We have node basins. Maybe I should try to use the little light here, right? Good luck. Good luck, that's right. Anyway, we have node basins which are located in the groin, the axilla, through the body. Thanks. Got it? Yeah, there we go. Okay. 70% of the system runs just under the skin. It's a really fragile system, so you can imagine with cancer treatment, it's easily damaged or impaired. Thank you. Gotcha. Right. All of these pathways are interconnected, superficial and deep, and all organs within the body have lymphatic vessels. The role of this system is to maintain homeostasis. It's to return proteins and fluids back to our circulatory system, and it's really a circulatory immune response within the body. It's integral in our fluid communication network.
So if we just look at a close-up now, this is just to give little snapshots really of the system. But if we look to a close-up here, you can see the skin on the surface here, and you can see the lymphatic system, the pre-collectors and the initial vessels are basically projected vertically to the surface of the skin, and they're a single cell. So they're very, very fragile, and there's no real propulsion at that point. Fluid just finds its way into this system because the collector system, or the vessel here at the bottom, this system has smooth muscle around it, and it works in a peristaltic fashion. So if it's drawing fluid forward, sorry, Leslie, if it's drawing fluid forward, then it's like a vacuum into the tissue spaces, right, to draw fluid, if everything's functioning as it should in a normal situation.
This is a look at the system just superficially, and really what I just want to make you aware of is when you're looking clinically at a patient, the system is divided into regions. So you can see by the dotted lines running down the center of the body and across the midline, those are the regions. So when patients have breast cancer, you're going to be looking for swelling in that one zone or region. They're called watershed lines. So what happens?
You need to stand closer to it.
Okay, so what happens is by the arrows, you can see how these superficial pathways are directed to the basins of lymph nodes. So from the lower limb, the fluid drains up to the groin. From the umbilicus down, it drains down to the groin. So if someone's having treatment for surgical intervention for like an ovarian cancer, you need to look for swelling just above the umbilicus and through the whole limb. As with the breast, it's you can see the lymphatic drain from the hand to the armpit or the axilla, and from the umbilicus up into the armpit across the chest wall. So as clinicians, when we're assessing patients for swelling, you don't want to just look at the limb, you want to look at the chest wall, the back, all of those areas can be impaired. And these are just superficial pathways, again, running just under the skin. And as Jan said, they're super fragile. They're easily damaged by things like chemotherapy, by surgery, past traumas, radiation. Yeah.
So the system, like a lot of systems in the body, has a safety factor built in so that we don't swell when we increase our circulatory demand for anything, whether that's exercise or running for the bus, if you're in Toronto, or whatever you're doing, you have a functional reserve in the system. So when, with activity here on the right-hand side, I have to speed up and rush for something, I still don't exceed the total capacity of the system if everything's working well. And the dotted line at the top is the total capacity. So that gets altered, and we'll talk about that as we go on here. Yeah.
So just to highlight what is lymphedema as a diagnosis, it's a diagnosis of exclusion. So it's kind of like irritable bowel syndrome. You'll do all sorts of investigations and then you'll say it's irritable bowel syndrome. Lymphedema is swelling of a body part. It's most often an arm or a leg. You can think back in the past when a woman's had a mastectomy and her lymph nodes removed from her arm, you'll see a huge swollen arm. That's what lymphedema is. It might be an arm or a leg, but it's the accumulation of fluids, and they're very high in protein. And there's an ongoing inflammatory response with this condition, and it results from impairment in the lymphatics. It can also just occur, if you think back to the slide I just showed you with all of those pathways and the dotted lines, it can occur in the face, the neck, the chest, breast, abdomen, groin, within the lungs. So you're getting an accumulation of fluid. And again, it's a diagnosis of exclusion. It's often picked up by frontline workers, like nurses or physiotherapists, massage therapists who have had extra training in this.
So we're sort of underlining different points, but lymphedema can occur from really two angles. And one of these angles we can affect a great deal. So this is why this slide's in here. So the transport capacity can be exceeded. You can be giving the system with its impairment too much to deal with on an ongoing basis, which means you're just going to have fluid build up and build up and build up. And or you could have the system already impaired. So, and that could be from other systemic reasons as well. So you have two main factors, and they interplay with each other. But we can do education on and lots of suggestions on these things. Yeah.
So this is a graph, and it's just to show you. Sorry, this feels like it's feeding back. The dotted line at the top, you have your normal maximal lymphatic capacity. So if you're just a person without a diagnosis of cancer or no impairment in your lymphatic system, your capacity would be the dotted line. And then you have treatment, and that cancer treatment, and that lowers your capacity to deal with fluids in the body.
Within the watershed zone.
Right, within that one zone.
Of the affected area, yeah.
So
yeah.
patients don't get full body swelling, they'll get swelling in the area with which they've had treatment. So here you can see certain stressors or changes in their life will impact their swelling. If they were at their normal capacity, you wouldn't see that clinically. But when it's been lowered because of lymphatic or because of cancer surgery or radiation, other stressors, you're going to see swelling. It's going to come and go. As clinicians, when you see the graph dipping down, we might not see the swelling, and it might be off our radar. So a patient might come to us and say, I have swelling in my limb, but by the time they show up to you, you might not see it, and we miss it. So it's often in the early stages, we don't pick it up, and we're not aware of what's going on.
And what all the new research is showing is that the most reliable early detection is listening to the client, listening to the patient. So asking the questions of their symptom pool. Why did they show up in your office? Because they have swelling that comes and goes, or they'll say, you know, my shoulder just really aches by the end of the night. I get some shooting pains sometimes. These sorts of things. And this is early surveillance, and it's scientifically being validated now. Yeah. This is the classification system for the International Society of Lymphology. And just as a point of reference, this is a very basic chart for edemas, but what we're talking about is organic, irreversible edemas here. However, don't write off functional reversible edemas, because our clients that undergo cancer therapy may down the road need a joint replacement, may down the road have a terrible fall on the ice, these sorts of things, and end up with other traumatic injuries that then tip the scale. And then we're dealing with both, because sometimes they don't have the capacity to recover completely from the functional problem or the short-term problem, because they don't have capacity to deliver enough nutrients to repair the area fast enough, for example. The dynamic edemas here are very related to other systems. So this is cardiac problems, renal problems, this sort of thing. We're not treating those people. We're not correcting that situation with the therapy here.
So lymphedema has 4 stages. We're working really hard with the model of care that we're providing in the area to identify people at stage 0 or stage 1 before they're clinically having swelling. This stage 0 it's really a latent or subclinical stage. Its swelling isn't visible initially, but the transport system for the fluid is impaired. This is the patient that will talk to you about tightness in the limb, heaviness, or burning when they're using the limb. It may exist for months or years before any swelling is ever seen. Stage 1 is an early accumulation of fluid. Again, this fluid is high in protein, so with time will become very viscous or thick. The swelling may come and go, and the edema might even be pitting at this point. Sometimes if the patient elevates for a while, the swelling will go. So these are early stages, again, often missed clinically because it comes and goes. And it might just be a transient thing with certain circumstances in their life. And as medical practitioners, we're not always really well educated with this, so we would say, oh, it's resolved. That's great, carry on. But there's a lot of groundwork that needs to be done with patients who have undergone treatment and had disruption to their lymphatics to prepare them and to advocate for themselves in this area.
There are also newer tools coming out for assessment that are being tested in terms of their validity. So bioimpedance is one of those tools. It's a more portable tool, and it's being marketed in the States a lot now. It's a little handheld unit that you can get to pass current through the surface of the skin, and you measure the resistance to flow. And a higher resistance to flow would tell you that you have subdermal swelling that's not showing as a visible or measurable surface swelling. So there is movement in this field, but still listening to your client. Just listen to the patient, hear their story. Yeah.
So stage 2, you'll see this swelling is accumulating and building up. Elevating the limb no longer, it doesn't really respond to elevation. It doesn't go down. So this is becoming more permanent now. It's a progression, as you can see or imagine. The edema may not be pitting, and because the fluid shifting is pulling proteins with it, the fluids again are thick, and you can't pit it anymore. You might get some fibrosis, and you're visually seeing swelling at this point. Stage 3 is end stage. This is where the limb becomes very large. It's unresponsive to treatment. You have a significant impairment in function. Again, if you think back to women in the past who have had mastectomies with all of their lymph nodes removed from their armpit or their axilla, and they get that huge swollen limb, it's not functional for them. Skin changes can occur, and you can think to lower limbs becoming thickened, discolored, getting crusty overgrowths on them. And this is called lymphostatic elephantiasis.
And this kind of client is often having repetitive infection cycles and skin breakdowns, ulcers, all kinds of things that are quite dramatic. So, yeah, we have a few pictures.
Yeah, so this is just a picture of the different types of lymphedema. The one you see here is an infant, and this is a primary lymphedema. So this child was born with an underfunctioning lymphatic system or underdeveloped. On the other side, you see a woman who's been through cancer care. She's post-cancer therapy, and you can see the significant swelling in that one arm and the changes in her skin. This would be the stage 2 or 3 that we just talked about. So her function would be impaired. That limb's very heavy. It's difficult to elevate to do your activities of daily living, and maybe employment would be impaired here. So really quality of life is being extremely affected at this stage.
And this secondary situation, this was a client of mine, and she could not find care for 18 months. So it just accelerated because she was doing all kinds of things in her life that just helped it accelerate, but didn't know she was, right? She was just trying to get on with life, right? So, yeah. I'm not. So again, functional edema, as you can see, this is someone with bilateral joint replacements, knee replacements. This woman, unfortunately, pre-surgically for her joint replacements was not diagnosed with an edema problem. She had an underlying condition that left her with this edema, and she unfortunately insisted on both surgeries at the same time. She did not want to be disrupted, and she ended up with an explosion of swelling, and she still manages that today. Now, she does manage it with us, but it's a very unfortunate circumstance, right? Yeah. There's a magazine called Pathways that is put out by the Canadian Lymphedema Framework, which is about 10 years old now. And several doctors did some research here about, minimum estimates. And I really underline minimum here because we're not capturing the numbers well in Canada, and so a lot is going undiagnosed and certainly being covered up by maybe another diagnosis. So these are minimum estimates. I don't need to read them all out for you, but the longitudinal studies that have been done worldwide, and there are several 20-year studies, one from Europe and one from the States, would double these numbers as people live longer. So just showing its significance. These are Canadian stats.
So a risk of a patient developing or progressing to secondary lymphedema would include the extent of surgery and the number of lymph nodes that are removed. We're really blessed now to have the option for a sentinel node, which allows us to identify and limit the number of nodes being removed. But again, that is another surgery, so further impairment to those superficial pathways that you noted just under the skin that get traumatized very easily. Radiation, looking at the size of the area and the depth of tissue penetration. Complications from surgery will predispose people to further swelling. If they've had infections of their incision or aspirations, to deal with seromas. Obesity certainly predisposes people to lymphedema. You can all think of somebody with a huge abdominal girth hanging down into their groin area, which would impair flow into the inguinal nodes, and then you get backup of fluid into the limbs. So with obesity, we naturally get more swelling, and then throw cancer care or treatment on top of that, and they're predisposed to developing lymphedema. Past injuries, when people have had surgeries for a fractured limb or skin conditions that lead to chronic inflammation, would predispose them to further swelling. And just note, when you have had disruption to the lymphatic system, wound healing is impaired. So they say it can take up to 4 times longer to heal from an infection, like a skin infection. So just overloading the system. We know that the capacity has been lowered because we looked at that earlier. So just physical, mental, emotional, spiritual factors that play havoc in our body can increase our risk for swelling.
So this last bright green bullet here, lack of information, in this field for a long time. And so 20 years ago, there was really dearth of information. Now we have more information, but sometimes it's delivered at times when the person can't absorb that information. So we have, clinics in hospitals they give information and this sort of thing. What we were finding was people needed some more personalized ongoing support. And so that's really what I'm talking about here, because every individual's different. In Jan's perfect world, because I put a lot of professional life energy into this, in my perfect world, the frontline workers see these proven risk factors and say, look, you got 3 of these, you're going to need help. And help that, or whatever it is. Or maybe someone will do research and validate those numbers at some point. But it's certainly necessary, yeah. So here we go. I think we should go quickly here. This is a venous thing. You can see again the recurrent infections causing the infection in the thing to the left here, and then obviously overweight and a large arm here on the right. This is elephantiasis. It does exist. It's a huge amount of work. There are never enough financial resources in how we live in our life to get on top of this. So there's a lot of pro bono work goes into something like that, and it can revert in months without ongoing care. So it's tough. This was a total hysterectomy. A woman who had no financial resources, was in a different country for quite a period of time for her family, came back, and you can see how bad it was, yeah.
So other common causes of edema can lead to lymphatic impairment and subsequent lymphedema. So we just want to be aware of other medical conditions as clinicians. Vascular disorders, systemic disorders, congestive heart failure, we've all seen that. Kidney impairment, thyroid conditions, DVTs with the lower limb swelling. Cellulitis and recurrent infections, inflammatory disorders, failure to heal wounds or ulcers. You get, again, more swelling and fluid retention. Post-surgical joint replacements, you've seen that today. Just a simple mosquito bite in somebody who's had post-treatment 10 years down the road might get a cellulitis and then pop into lymphedema. In third world countries, we have a condition called filariasis, and it's actually a parasite that invades a node basin, often in the groin, and takes over, and then you don't have the flow of fluid and you get lymphedema. So it's from parasite infections as well, and past traumas make us predisposed. So what we're seeing now is somebody might have had their cancer treatment 10 or 15 years ago. They might have had some nodes removed and they're predisposed to swelling, but maybe had nothing for that time, and then had a flare-up of congestive heart failure, and their limbs would swell more than we would expect. But don't lose sight of the cancer treatment that happened 15 years ago that make them at risk for further swelling.
This is kind of a link. Go through it completely. You can see that we link the stages with symptoms. Okay? Yeah. Did we get? No, we're still doing some. Yeah. I got a little overzealous. I made too many slides. It's true.
So this is just again because things don't always. Lymphedema. So you can see here at point 0, they've had the clients had their surgery with a lymph node dissection and maybe some chemotherapy. Post treatment there, they might develop a wound infection and have some swelling that slowly resolves. And then maybe a seroma develops and they have to have that fluid aspirated with a needle, and then that kind of resolves. They go on to have their radiation therapy, swelling occurs again. But what you're seeing is within the limb or the affected watershed area, the zone we talked about earlier, the swelling is slowly accumulating. We might not be seeing it clinically, but it's building up and congestion is accumulating within the limb. So after that treatment, they're super happy, cancer's over, and they're going to live their life, and they hop on an airplane. Well, we all know with altitude changes, you get fluid movement and shifting. And so, again, they get more swelling. And they might think, oh, it's just from the plane. Then they get to their destination and get a bad sunburn. That's further inflammation and swelling. And you can see just slowly over time, they're at risk for developing lymphedema. So what we're trying to do here in our community is work to help patients know that this could be a problem down the road. Dr. Lisi's great about referring his women who have undergone breast cancer surgery or melanomas where the nodes have been disrupted possibly, so that we can work with patients to pick them up at stage 0 or 1, to provide them with education so that they can advocate for themselves, because often patients with this condition will show up in emerge, and as physicians, we don't know what it is. We go, no, it looks okay, you're fine. Or they go to a hospital to have blood work, and they want to take insert an IV in that limb. Well, that would make them at risk for infection because that's a compromised watershed or zone. So we want patients to advocate for themselves to prevent progression or just prevent developing this condition.
Well, and these days a lot of people have heard more about lymphedema, the internet and all of that, or they have an aunt or a mother or someone, friend that had it, and they're afraid, and information dispels fear. So if you educate up front, then people, if and when they need care, can access it, or perhaps they already need care, but you can mitigate the progression process, and we see that clinically all the time. When you do early care in the stage 1 area, that person doesn't become stage 2, doesn't become stage 3. Yeah.
So we've talked about these things. Just remember, anything that can cause swelling in the body in somebody who's had a compromised watershed area can lead to swelling. So just don't forget these things. We've already covered them, so we'll move on from that.
Yeah. So just for the research piece there, if anybody is interested in some studies, I have brought a few, and they're certainly coming out more and more right now about early detection. Okay, so out of Australia, out of NIH just published something last week, and there's another research paper coming out of lymphatic research and biology in the States. So all these things are being validated, even though we were living them clinically, this kind of thing. Yeah. So best practice is combined decongestive therapy, and there is a poster out here too, been done. Yay! By Laura, who works locally here, as well as myself, and combined decongestive therapy is 5 things. So it's rerouting the fluid, it's providing the appropriate compression, and that can vary during a treatment cycle depending on, are you trying to bring the limb down, are you trying to maintain things, do you just need something for the exercise program or the air flight that you're going on, or these sorts of things. And a trained professional makes those decisions with the client. There's education about lots of things, lifestyle choices, how not to exacerbate things, these sorts of things. Exercise, of course, the more efficiently our muscles work, the less perfusion we have into them to do the things we want, which mitigates fluid problems. Self-massage, integral part of a home care program. So the point of all of this combined decongestive therapy is independence to manage this. Yeah.
So locally, again, we've been doing this kind of work for about 11 years. We receive referrals from oncologists, internal medicine, surgery, physiotherapists, RMTs in the community. I've sent patients to me. I'll see them for a consult, help with a diagnosis. One of the things I offer clients is I've registered with the government. This is just the model that we're working with, to be able to authorize their ADP forms. ADP is a program, assistive devices program, and the government will actually pay 70% of compression garments for patients.
Your tax dollars that way.
But they're super expensive, and they don't last forever, so they'll pay for 4 sets a year. And so I sign that form for the clients that I see. They go on to see Jan because she needs, or Laura, an authorized CDT therapist. They need a signature from them as well. Yeah. And then from there, we refer them to a fitter. So a fitter is somebody who just full-time, we advocate for a full-time fitter, fits clients with garments. They're aware of all of the different products out there. They'll troubleshoot with the patient. If it's rubbing or it's causing pressure points, they'll send it back and have fabric put in so it's comfortable for them. This is different than, say, like a home shoppers who has a fitter within their drugstore, because they're not aware of all of the products. This is very different. So we make sure that the client actually gets to the people who are well trained in the area and can offer them products that are most helpful to them.
And the CDT here you see for physio, so it's beyond just the signature. I just had to say that, it's my ego. Okay. I think we're done. like these are just other resources. Yeah.
Show the picture of the compression.
Oh, yes.
I just want to show you.
Leslie wants you to see this.
This is the compression garments that we're talking about. Here's is a woman post breast cancer. She's wearing a sleeve and a gauntlet. Again, there's some padding in the hand, within the hand gauntlet, just to help decrease the swelling. There's all sorts of really fun products out there now. There's a company called Lymphedema, and they make sleeves that look like tattoos. They have different colors, and so we try to provide clients with emotional support, make it not so devastating for them. And this is bandaging. It's a special type of bandaging that we'll use to get the swelling down. No, I say we, this is Jan and Laura, to get the swelling down before they're measured for, excuse me, compression. And that's the end of the journey.
Great, I'll just see if are there any questions? Great, we've got some here.
From the primary care perspective, we have women come in after mastectomies and they say, well, we can never have our blood pressure taken on that. It sounds like it might be a bit therapeutic for them to compress and re-wrap. I'm being facetious, so but can you speak to that? Why do we have to avoid taking blood pressure?
Sure.
Or I can. So as you're increasing the pressure, you're increasing just that compression on that really fragile system that runs just under the epidermis. So really what we're trying to do in our education is help patients to know that anything that causes inflammation or swelling puts them at risk for lymphedema. So we say no trauma, even micro trauma, because when the therapy that Jan and Laura provide is actually manually moving the fluid, it's such a light touch you'd almost think it's doing nothing. So compressing it to that degree can cause swelling. You're welcome.
And part of the problem is we don't know where every there isn't a Geiger counter I can put on a certain body to know how much safety factor they've lost. So any small thing could just tip someone over, and if that's you, you're not too happy. Yeah.
Should patients who are at risk of lymphedema avoid regular massages?
That's a really good question. So she asked, should patients that are at risk for developing lymphedema avoid regular massage? So it's a bit of a gray answer. The quick answer is yes. But the long answer is just in that zone, that area, they should not have deep work. A lot of deep work causes micro-inflammatory response, and lymphedema, when it is long-standing, is a micro-inflammatory condition because the proteins that build up in the tissues are an irritant to the tissues. So I'd be happy to talk with you later if you want more.
Great. Thanks, Liz. Thank you. Thank you so much.